Thank you for joining us for the Dispatch from the Front. Lessons learned at the collision of public health, peer support, and a rising tide of hope webinar. Whether it's morning, afternoon, or evening, wherever you are, your presence here matters. My name is John Picard, and I'm honored to moderate today's event. This series is proudly hosted by the Colombo Plan, the International Society for Substance Use Professionals, ISSUP, Faces and Voices of Recovery, and the Global Recovery Network. These organizations are working together to strengthen recovery systems worldwide. While we are waiting for a few more of us to join, I will begin by saying a little bit more about ISSUP, a membership organization for the global substance use workforce with over 35,000 members worldwide. It is an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery support workforce. ISSUP's global mission is to make the work of members an impactful, accessible, and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practices, training, and network opportunities. If you've not done so already, please head over to ISSUP's website, issup.net, that's ISSUP.net, where you will find information on how to sign up for a free membership. The website also has a wealth of resources and publications for you to enjoy. You can watch recordings of past webinars and see future event listings. So I'd like to thank the ISSUP staff for providing technical support for this webinar and the previous webinars and our last one, which is going to be in 2 weeks. This is a 6-part series taking place every other Tuesday, concluding on September 30th, International Recovery Day. Each phase of this series focuses on building knowledge and capacity across 3 specific areas: core foundations to recovery, returning to basics, and leadership development. Today's session starts our leadership development phase. Today, we journey into Dispatch from the Front, lessons learned at the collision of public health, peer support, and a rising tide of hope. It's my pleasure to introduce our speaker, Cynthia Moreno-Tui. Very warm welcome to you, and it's a great pleasure to have you with us. Cynthia is the former executive director of NAADAC, or NADAC for short. It's the Association of Addiction Professionals, and has worked as an addiction professional for over 40 years. She previously served as the executive director of Dania Institute and the Central East Addiction Technology Transfer Center. Prior to this, she was the program director for Volunteers of America, Western Washington, serving homeless populations and dealing with the co-occurrence of poverty and substance use and co-occurring disorders. In addition, she has been the administrator of multi-county publicly funded substance use prevention, intervention, treatment centers, with services ranging from prenatal care to serving the elderly for over 20 years. Moreno-Tui is an international and domestic trainer in conflict resolution, anger management, rein in your brain, I love that, foundations of addiction practice, clinical supervision, counseling skills and methods, medication-assisted treatment and recovery, and many other topics for the past 25 years. She's the author of an NIDA SBIR, which is titled Conflict Resolution in Recovery and Relapse Prevention, and a published author of the book Rein in Your Brain, From Impulsivity to Thoughtful Living in Recovery, published by Hazelden. She has served as president of NADAC, a certified board commissioner, international chair, treasurer, and legislative chair for NADAC as well. She has experience in developing and implementing programs in leadership, organizational development training for emerging managers, training trainers, and training mentors. She has developed partnerships with various national and international organizations, including developing strategic plans, workforce development plans, and implementation and educational curriculum. Cynthia has written training components and manuals regarding adolescents, adults, seniors, school intervention, involuntary commitment, community mobilization, intensive outpatient and continuing care, impaired drivers programs, EAP, which is an employee assistance program, and gang intervention suppression treatment. She holds a bachelor's degree in social work and administration and is certified both nationally and in the state of Washington. So today's lecture is going to be, and webinar is going to be very informative. Cynthia's got a lot of experience and I'm excited. But before we get started, I'd like to go over a few items so you know how to participate in today's event. Today's session is in English with interpretation available in Spanish. Please check for the link in the chat to access that Spanish interpretation. This session will be recorded and you will receive the slides, video, and resources via email after the session. You will have the opportunity to submit text questions to our presenters by typing your questions into the questions pane of the webinar interface on your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. And now, it is my pleasure to hand over the webinar to our esteemed presenter, Cynthia. The floor is yours.
Thank you so much, John. I really appreciate that introduction. I know it is a little long, and I realize that now. So thank you again for sharing that, and we'll get started. So I'm excited to be with you this morning. For me, it is a little bit after 6 a.m. on the West Coast of the United States. So I'm proud to be a person in recovery as well as a past administrator for NADAC. John already covered the housekeeping, so we're not going to spend attention on that. We always talk about being open-minded, respectful, having engagement, encouragement to engage. Know that there may be some things that touch you, and it's okay to talk about that when we do the Q&A. And stretch yourself a little bit. There may be some things in here that you may go, not sure about. It's okay. We can stretch and talk about those things. And confidentiality. If anybody has anything confidential that they share in the Q&A, we want to keep that confidential, please. I'll talk a little bit about the learning objectives so you know what we're in for. We're going to identify various global approaches to substance use disorder and recovery supportive services. We're going to distinguish leadership roles in public health and peer support implementation. We're going to identify key lessons learned from real-world examples at the intersection of public health and peer support. We're going to describe the role of leadership in public health and recovery support settings. We're going to describe the value of integrating peer support into public health systems. And we're going to explain how HOPE can be operationalized as a strategic component of recovery and resilience. So it's going to be pretty exciting to go over these things. We're going to explore all of these things and see what happens in the public health system. This isn't just a webinar, it's a dispatch, a report from the front lines of leadership and change. You'll hear stories, lessons, and reflections that speak to the heart of what's possible when we center humanity in health. By the end of the webinar, you're going to be able to describe some of these peer support and public health systems. So defining recovery. SAMHSA's definition of recovery is recovery as a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. This definition is not limited to a single point in time, but rather describes an ongoing process. A universal definition, despite growing consensus on the importance of a holistic approach, a universality agreed upon definition of recovery, especially operationalizing it, remains a challenge. Well, why is that? Why is it a challenge? Challenges that contribute to the adoption of a universal definition include diverse interpretations of recovery, uneven policy enforcement, and quantifying recovery. Different cultures and contexts may have varying understandings of what constitutes a recovered state. A recovery approach and government interventions around recovery are more prominent in English-speaking countries compared to other regions like Central and Northern Europe, Asia, and Africa. Measuring recovery, quantifying recovery, can be complex as it involves both objective improvements like employment and non-objective experiences like well-being. So advancing recovery supports. The UNODC, which is the United Nations Office on Crime, Drugs and Crime, works with WHO, which is the World Health Organization, to support member states in enhancing the quality of drug use disorder treatment services and systems, including incorporating peer support based on international standards. NAPS, which is the National Association of Peer Supporters, was dedicated to promoting and supporting peer support in behavioral health systems. This organization is now defunct. SAMHSA works including promoting evidence-based practices, fostering recovery-oriented systems of care, and advocating for the inclusion of recovery supports in various settings, including healthcare, courts, and correctional facilities. Oh, you gotta watch me, I'm going the opposite way. Global and public health approaches for recovery supports. A global approach to addiction recovery involves recognizing the complexity of addiction. This approach embraces a public health perspective. It implements evidence-based interventions tailored to diverse cultural contexts and fosters supportive recovery environments. Addressing treatment access barriers and promoting integrated person-centered care can help and does help more individuals achieve and maintain long-term recovery. The public health approach views addiction as a health issue rather than solely a criminal justice matter and focuses on prevention, harm reduction, and disease management. Conceptualizing peer recovery supports. Well, you know, the global health, public health interventions for addiction and alcohol use disorder include a range of strategies that focus on prevention, treatment, and recovery support, harm reduction, and these interventions are aimed to reduce the burden of alcohol and substance use disorders on individuals and societies. The conceptual analysis article on systemizing peer recovery support services for substance use disorders, a taxonomy for measuring recovery milestones, aims to introduce a systematic taxonomy to clarify the roles, functions, and activities within the peer recovery support services system. It provides a structured framework for evaluating their impact on substance use disorder recovery milestones. This compromises or compares 6 primary taxons and 20 branches, and the taxonomy organizes all around recovery peer support. These components are structured into categories. It classifies variations in lived experience, direct, indirect, and hybrid. It also gives training levels. So there's the basic, the specialized, continuous education, formal education, and certification types. Additionally, it categorizes peer support activities into 4 core domains: emotional, informational, instrumental, and affiliational supports. The taxonomy approaches and integrates a structured model for peer recovery support services evaluation, identifying mentors, support approaches, and moderators that influence recovery outcomes. So the important piece about this slide is that we look at opioid abatement effects and the strategies and programs designed to affect opioid epidemic, focusing on prevention, treatment, and recovery from opioid use disorder, or OUD. Broadening access to naloxone, expanding training and distribution of naloxone, a medication that can reverse an opioid overdose, to first responders, to individuals with OUD, to their families, their friends, schools, and the general public. So just broadening that out across the community. Supporting use of medications for opioid use disorders, or MOUD. Increasing access to effective medications like methadone, buprenorphine, or naloxone, and combining them with behavioral therapies and counseling to treat opioid addiction. Improving treatment and recovery supports in jails and in prisons, expanding that access to all these forms of MOUD and linking incarcerated individuals with community-based treatment upon their release. Expanding prevention strategies. This is implementing evidence-based, informed school and community-based programs for youth and providing support for parents and for caregivers. It means expanding harm reduction services, supporting programs like syringe service programs that provide sterile injection equipment, overdose prevention tools like fentanyl test strips, and referral to treatment and other services. Increasing access to safe and effective therapies for pain, supporting efforts to prevent opioid overprescribing, promoting non-opioid pain treatment alternatives, and training healthcare providers on safe opioid prescribing practices. Reducing misuse of opioids means supporting public health efforts, facilitating drug take-back and disposal programs for medications, and engaging community coalition in preventive initiatives. It also means supporting first responders, providing education on appropriate practices when dealing with fentanyl and other drugs, and increasing access to wellness support services. We also need to enhance data collection and research, evaluating abatement programs, supporting workforce development, and collecting data to monitor trends and inform strategies. Key principles for opioid abatement include prioritizing, saving lives. That's why we do what we do. We want to save lives. We focus funds on strategies proven to reduce opioid rates, overdose rates. Using evidence-based approaches, implementing programs and strategies supported by scientific evidence, investing in youth prevention, dedicated resources to preventing opioid misuse among young people. These are all important policies of addiction. And focusing on equality. Ensure equitable distribution of resources, particularly for communities historically disadvantaged by the opioid crisis. Implementing a transparent process, establishing clear processes for allocation and spending the funds. So let's have an overview of medications that people can access for alcohol use dependency and opioid use dependency and opioid overdose reversal. Medications do play a crucial role in treating opioid use disorder and alcohol use disorder, as well as in reversing opioid overdoses. For opioid use disorder, the FDA approved medications like methadone, buprenorphine, and naltrexone are used to reduce cravings and the euphoric effects that opioid gives to the brain. For alcohol use disorder, medications like disulfiram are known as Antabuse, acamprosate, and naltrexone are used to reduce alcohol consumption and cravings. In the case of opioid overdose, naltrexone is a life-saving, naloxone is a life-saving medication that can reverse the effects of the opioids. So, due to a limited time today, we're going to only highlight and review some key points. So global and public health approaches that have worked for opioid abatement efforts include medications for opioid use disorder, as we just talked about, for MOUD, and for opioid antagonist treatment. In Europe, OAT is often integrated with low threshold drug counseling for high-risk opioid use, leading to high retention rates in the care of persons with opioid use disorder. Countries like Switzerland, Austria, and Germany provide easily accessible and free OAT. The Maldives offers free methadone maintenance treatment through a government clinic through the number of slots. Though the number of slots are limited, they do have a free clinic for this. For overdose reversal, Australia has rescheduled naloxone, allowing it to be available in pharmacies without a prescription. Very easy access. The Czech Republic, Germany, France, Italy, and Norway also have programs to increase naloxone availability, while Ireland is piloting now similar initiatives. Some libraries in the United States have started providing naloxone in wall-mounted boxes for easy access. In Portugal, decriminalization and harm reduction. In France, expanded access to buprenorphine as primary care. In Switzerland, accessible methadone and OAT. So in many countries, they are looking at naloxone availability to help support recovery. So let's talk a little bit about the promoting access to youth recovery support programs. Substance use disorder recovery programs are evolving to better serve young people, recognizing their unique needs and their developmental stages. While recent data shows positive trends in overall youth substance use, there's a concerning rise in overdose deaths among adolescents, particularly involving fentanyl. These trends highlight the importance of adapting substance use disorder recovery approaches to effectively engage and support youth. So there are alternative peer groups. There are recovery high schools. There are collegiate recovery programs and communities. And there is young people in recovery. So what are APGs, alternative peer groups? Alternative peer groups are structured programs designed to support young people in recovery from substance use disorder by providing a safe, substance-free environment with peer support, social activities, and family involvement. They offer a unique approach to aftercare, or continuing care as we call it now, and recovery by focusing on social components, individual and family counseling, and psychosocial education. Founded in 1971 in Houston, Texas, Recovery High Schools, schools designed specifically for students recovering from substance use. Recovery schools provide an academic service and assistance with recovery, including post-treatment support and continuing care. They do not generally operate as treatment centers or mental health agencies. The Phoenix School in Silver Spring, Maryland, is the first documented recovery high school, and it was established in 1979. When I first went into recovery, there were no recovery support programs for youth. And so we really have advanced through our decades to actually provide these programs. We now have collegiate recovery programs in communities. A collegiate recovery program is a college or university provided program that provides supportive environment within the campus structure. CRPs reinforce the decision to engage in a lifestyle of recovery from addiction and substance use disorder. It is designed to provide an educational opportunity alongside recovery supports to ensure that students do not have to sacrifice one for the other. The first collegiate recovery program was established in 1977 at Brown University. Again, had those programs been available years ago, recovery would be so much easier. Now we have the opportunity to engage youth in recovery supports that we haven't had historically. YPR, or Young People in Recovery, was founded in 2010 by young people, and young people is defined as people under 30. YPR is a national nonprofit that provides peer support services for youth and young adults in recovery, or who are seeking recovery from substance use disorder. Their program consists of community-based chapters, life skill curriculum programs, and advocacy to reduce stigma and create more resources for recovery. By creating a national network of young people in recovery, YPR empowers young people to get involved in their communities and take charge of their own futures. So a global and public health approach to youth and addiction emphasizes prevention, early intervention, and harm reduction strategies, recognizing that substance use is influenced by the individual, by the environment in which they live, and by social factors. This approach prioritizes understanding the specific context in which young people use substances and tailors interventions accordingly, while also promoting collaboration between the stakeholders. UNODC Youth Initiative aims to connect young people from around the globe and empower them to become active in their schools, communities, and youth programs for substance use prevention and health promotion. It provides a platform for youth to share their experiences, ideas, creativity, and to get support for creating their own prevention and health promotion activities. Activities include the Youth Forum, DAPC grants, and Friends in Focus. In Sweden, Norway, and European countries, they are utilizing interventions like the Cannabis Cessation Program, or CCP, and the Motivation to Change inventory for adolescents. This has been adapted for Icelandic context, and the Norwegian Multi-System Therapy Program, or MST. Developing countries like the Ukraine, Philippines, Nigeria, and Peru are working to develop addiction public health infrastructure with support from organizations like UNODC, focusing on regulatory changes, workforce development, and resource allocation. This is all according to the National Institute on Health, or NIH. Parity. Parity refers to efforts to ensure healthcare coverage for substance use disorders and mental health conditions is equivalent, the same as the coverage provided for medical conditions and surgical procedures. The history of substance use and alcohol use parity in the United States involves a shift from treating addiction primarily as a moral or criminal issue to recognizing it as a medical condition deserving of comparable health insurance coverage as other medical conditions. Substance use and alcohol use are increasingly being acknowledged as a public health crisis that leads to illness, injury, death, and social and economic disruption. I have been blessed to work on the parity process in the United States, and it was a struggle that took about 16 years. So we don't give up on making things happen or change happens. So global and public health approaches around parity involve systems to minimize parity issues. So single payer health systems. A single payer health system is where costs for healthcare are created and covered by a single public healthcare system instead of all these multiple ways of covering healthcare. It also involves integrated care models, integrating mental health and substance use disorder services into the primary care setting. And I want to say it's also the opposite, that integrating primary care into mental health and substance use services. So it can go both ways. Cost elimination or reduction of copays, so people can afford to go get the treatment that they need. Workforce development. So this is peer and lay health workers to address shortages of psychiatrists and psychologists, and in some places, addiction specialists. Social determinants of health, using social policies to help with parity for health care issues, harm reduction and treatment and innovations, harm reduction centers, supervised injection sites, and comprehensive support networks. These are all ways to help support parity. Okay. So what about international efforts? In essence, international efforts are moving toward a more holistic and person-centered understanding of recovery, recognizing that it encompasses a wide range of individual, social, and economic factors. International organizations play a vital role in promoting evidence-based practices, providing technical assistance, and advocacy for policies that support individuals in achieving and maintaining recovery. So lessons learned in public health and recovery support. In essence, successful integration of peer support into public health requires a commitment from leadership to champion the model, foster a supportive environment, and address the unique needs of the peer recovery workforce. This is all according to the National Institute on Health. Creating a vision. So public health leadership plays that critical role in fostering and integrating peer support programs, which have demonstrated effectiveness in improving healthcare outcomes, particularly in mental health and chronic disease management. So these are key lessons learned regarding leadership and peer support in public health. So creating a vision, yes, championing peer support leaders, and articulate a clear vision for integrating peer support into public health initiatives and championing, supporting its value within the organizations and to external case stakeholders. Building a supportive culture means cultivating a culture of trust, collaboration, and mutual respect and mutual support is essential for peer support programs to thrive. This involves addressing stigma, promoting psychological safety, and fostering an environment where seeking and providing support is normalized. Providing resources and training. Leadership is responsible for securing the necessary resources, including staffing, funding, space, equipment, and providing comprehensive training for peer support specialists and their supervisors. It means establishing clear policies and procedures. Clear guidelines and policies are needed regarding peer support roles, responsibilities, confidentiality, boundaries, and supervision to ensure ethical and effective practice. Facilitating integration and collaboration. Leaders need to actively integrate peer support into existing public health services and foster collaboration between peer support specialists and other healthcare professionals. Evaluating and adopting programs. So regular evaluation of peer support programs is necessary in order to assess, evaluate their effectiveness, identify areas for improvement, and adapt to changing needs and contexts. So it all is there to cultivate success for the clients or the persons in which we serve. Learned lessons in leadership in peer support implementation. So acknowledge and addressing peer dynamics. Leaders and supervisors need to be mindful of power imbalances between themselves and peer support specialists and actively work to create a more equitable and inclusive environment. We need to provide adequate supervision. Adequate supervision is specialized supervision that acknowledges the unique role and experience of peer support specialists, that it's critical to their well-being and their professional development and the overall success of the programs. Clarify roles and responsibilities. Clearly define job descriptions and expectations for peer support specialists that can help them address role confusion and integrate them effectively into healthcare teams and healthcare systems. Address stigma and discrimination. Despite growing acceptance, peer support specialists may still experience stigma and discrimination. Leadership needs to be proactive in combating these issues and advocate for the value of peer supports. Peer support specialists self-care. This is vital. We need leaders to encourage and provide resources for peer support specialists to engage in self-care activities to mitigate the risk of burnout and ensure their ongoing well-being, to ensure that they're remaining in their own recovery. And now we're going to talk about integrating peer support into public health systems. So we're going to talk about one of the most powerful aspects of peer support, and that is its ability to build trust and drive meaningful engagement. Peer supporters bring something that's traditional to healthcare systems that often struggle to offer lived experience. So So that's what it brings, is that specialness of having lived experience. This shared experience creates a sense of authenticity and reliability and relatability that can break down barriers. For individuals who may be skeptical of clinical providers or systems, especially those from marginalized communities, seeing someone who has been there, done that, can make all the difference. And it's not just about feeling understood, it's about action. When trust is established, people are more likely to engage in services, follow through with treatment, and remain connected. Take substance use disorders, for example. Research and real-world experience show that individuals are far more likely to enter and stay in treatment when approached by someone who has walked a similar path. They share a shared journey that builds on the credibility and hope of each other. So peer support isn't just a nice to have, it's a strategic approach to improving outcomes, especially for those who have historically been left behind. So peer support brings lived experience, which fosters authentic connection and trust with individuals who may be weary of traditional health systems. This trust leads to higher engagement. So one builds on the other, especially among marginalized or underserved populations. And that example is that people with substance use disorders are more likely to engage in treatment when approached by someone who has walked a similar path. And we have seen this over and over again in the treatment world and in the peer recovery support world. Improves health outcomes. Peer support doesn't just feel good, it's effective, it works. It leads to measurable improvements in healthcare outcomes. So let's talk about that. When individuals feel supported and understood, they're more likely to stick with treatment plans. So we said they're more likely to stick with treatment. Well, they're also more likely to stick with their treatment plan, attend follow-up appointments, and adopt healthier behaviors. In programs where peer support is integrated, we see reductions in hospital readmissions, improved mental health care scores, and better chronic disease management. These are all effective strategies that build not only recovery, it reduces costs. And these outcomes don't just benefit the individual, they reduce strain on the healthcare system. And as I said, they lower costs and they help families recover. And that's really important. So peer support has shown to improve outcomes in areas like mental health, chronic disease management, HIV prevention, and maternal health. It helps support self-management, medication adherence, and emotional resilience. It helps with diabetic care. Peer-led interventions have led to better glycemic control and reduced depressive symptoms. These are all wonderful benefits of improved healthcare systems. Reducing stigma and promoting equity. Stigma can be one of the biggest barriers to care, especially for mental health, substance use, and other chronic conditions. Peer supporters challenge stigma simply by showing up. Their presence normalizes the experience and shows that recovery and wellness are possible. When someone says, "I've been there too," it shifts the narrative from shame and blame to strength and wellness. The shift doesn't just help individuals, it transforms families, communities, and care environments. Peer supports normalize the conversation around mental health, addiction, trauma, and recovery. It helps reduce stigma and challenge discriminatory practices within the healthcare system. One example is youth-led mental health programs in Kenya. They've shifted cultural attitudes and increased help-seeking behavior. Another critical value of peer support is how it strengthens community-based care. This is especially true in settings where formal healthcare infrastructure is limited or not even accessible. Peer support is inherently local. It builds on relationships, trust, and shared experiences. This makes it ideal for decentralized public health models where care needs to be delivered in homes, in schools, in shelters, and community centers. In humanitarian settings, for example, peer networks have helped maintain continuous quality of care for people with chronic conditions like diabetes and hypertension. Even when clinics are overwhelmed or disrupted in rural Colombia, peer facilitators have helped communities heal from trauma and rebuild social cohesion after conflict. Community-based care is also more sustainable. Peer-led programs often cost less, reach more people, and adapt more quickly to local needs. They're not just delivering services, they're building capacity, resilience, and ownership. When public healthcare systems invest in peer support, they're not just extending their reach, they are deepening their roots. So peer support is inherently community-centered, making it ideal for decentralized public healthcare models. It complements clinical care with social and emotional support, often in low-resource settings. And an example is the humanitarian context. Peer networks help maintain that continuity of care for non-communicable diseases. From a systems perspective, peer support is a smart investment. Peer programs are relatively low cost to implement, and yet they deliver high impact results. They're also scalable. With proper training and support, peer networks can grow quickly to meet the rising needs and the rising demands in their community. If we're serious about equity, if we're serious about outcomes, positive outcomes, and sustainability, peer support needs to be part of that strategy. Peer support programs are cost effective, especially when compared to traditional clinical interventions. They are scalable across diverse settings, from prisons to schools to refugee camps. An example is group counseling led by peers in the schools in Kenya boosted coping skills by 50% at a lower cost rate. One of the most powerful outcomes of integrating peer support into public health is its ability to catalyze system change. Peer support improves individual outcomes and challenges and reshapes the very systems that deliver care. When people with lived experience are embedded in public health programs, they bring a different kind of intelligence. It's emotional, cultural, and experimental. It is a shift how services are designed, how policies are written, how care is delivered. We've seen this in places like Scotland, where peer recovery coaches in prisons aren't just supporting individuals, they're influencing national harm reduction strategies. Their presence has led to more trauma-informed practices, better staff training, and a rethinking of what rehabilitation or habilitation can look like. Systematic change also happens when peer support is recognized as a profession with certification, career pathways, and leadership roles. This elevated lived experience from antidote to expertise, and it embeds hope, dignity, and equality into the fabric of public health. In short, peer support is not just a program, it's a paradigm shift. When integrated into public health care systems, peer support can actually reshape delivery, inform policy, and drive innovation. It brings that humanizing lens to healthcare. It emphasizes dignity, respect, hope, and lived wisdom. As we said, Scotland's prison recovery coaches, they are influencing national harm reduction strategies. So now we're going to begin with a few dispatches. This is leadership in action, real stories from the ground. These are moments where peer support and public health didn't just intersect, they transformed each other. And these examples provide tangible case studies of leadership in action. First, we traveled to Scotland, where peer support is being used in one of the most challenging public health environments, and that is the prison system. Recovery coaching in Scotland trains incarcerated individuals with lived experience to become certified recovery coaches. These coaches support others in managing substance use and rebuilding their lives, both inside and outside the prison. Through the Recovery Coaching Scotland initiative, incarcerated individuals with lived experience of substance use are trained as certified recovery coaches right in the prison. These peers provide support to other people inside the prison, helping them navigate addiction, trauma, and the journey toward reintegration into the community. This isn't just a rehab program, it's a public health intervention. The training curriculum includes trauma-informed care, emotional intelligence, and employability skills. What's striking about this program is that it's a cultural shift. Staff and residents alike report a change in the atmosphere, more trust, more openness, and more hope right inside the walls. Peer coaches are supporting recovery and reshaping the prison environment. The lesson here is clear. Peer-led recovery is effective, even in restrictive settings. It's cost-effective, trauma-informed, and deeply humanizing. When embedded in public health strategy, it becomes a systematic change. So the impact, over 200 prison residents trained across 5 prisons in Scotland. Programs include, as we said, trauma-informed recovery, emotional intelligence, and employability skills. It is a cultural change, and it is observed not just by the prison staff and the residents, by the administration as well. And leadership in public health and recovery support includes creating, as we said before, a vision and championing peer support, build a supportive culture, and provide resources and training. Now we turn our attention to Kenya. Remarkable initiative called Story Yanga, which means my story. It's transforming how young people engage with mental health. The Sori Yunga initiative empowers high school students across Kenya to share personal mental health experiences, build peer support networks, and reduce stigma. It's part of a broader national effort that includes school-based wellness programs, community awareness campaigns, and AI-powered mental health support. This program empowers high school students to share experiences with mental health challenges, creating peer support networks that are not only safe and affirming, also they're deeply effective. It's a part of a broader national movement that includes school-based wellness programming, community awareness campaigns, and even AI-powered mental health tools. What's powerful here is the scale and impact, and the data is compelling. This is public health in action. It's treating illness, building resilience, and it's youth-led. These students are recipients of care and architects of change. They're reducing stigma, increasing access to care, and creating a culture where it is okay to talk about mental health. The key lessons here is scalability and cultural resonance. It's low resource settings. Peer support isn't just a good idea. It's a strategic necessity. When young people are empowered to lead, they become catalysts for community-wide transformation, change that is necessary in the community in order to become happier and healthier. As we think about global models, Kenya reminds us that innovation doesn't always come from high-tech labs or policy think tanks. Sometimes it comes from a classroom, a conversation, the courage to say, this is my story. So over 20,000 individuals have been reached across 47 countries. Peer-led programs prevent up to 30% of future mental health issues. Group counseling boosts coping skills by 50% at a significant lower cost. So again, we're creating a vision, we're championing peer support, we're building a supportive culture, and we're facilitating integration and collaboration. What is the impact? So another powerful example in action can be found in the integration of peer support into public health systems, particularly around crisis response. In an urban community facing high rates of behavioral health emergencies, the local public health department partnered with a peer-run organization to rethink how crisis calls were handled. Instead of sending police or emergency medical teams to nonviolent behavioral health situations, they launched a mobile crisis response team staffed by certified peer specialists. The public health department partnered with this peer-run organization to launch this mobile health crisis response team, staffed by peer specialists instead of police or emergency medical technicians. They trained the peers to respond to nonviolent behavioral health challenges, to respond with empathy, to respond with de-escalation skills, and a recovery-oriented mindset. They weren't there to control the situation. They were there to connect. And in that connection, change happens. The results were remarkable, with dramatic decreases of people in distress being funneled into chaotic clinical environments. These programs led to more people getting the right support at the right time, in the right way, and increased engagement of populations who often felt alienated by traditional systems. The key lesson here is that peer support can de-escalate crisis and redirect individuals toward recovery, not punishment or hospitalization, not lockup. It reduces strain on the emergency systems and improves outcome to both cultural and clinical and social contexts. This model is scalable, cost-effective, and deeply human. It's a blueprint for how public health can evolve by putting lived experience at the center of crisis. The impact has been 40% reduction in emergency room visits for behavioral health crises. Emergency room visits are the most expensive visits in a hospital. It increases trust in public health services among marginalized populations, and peer responders report higher engagement and follow-up rates than traditional responders. Again, we're building a supportive culture. We're providing resources and training, and we're facilitating integration and collaboration. Leadership is the backbone of any successful public health initiative. And when it comes to integrating peer support, positive leadership is not just helpful, it's transformative. So the impact of that is when leaders champion peer support, they send a clear message that lived experience matters. This builds trust within the workforce and also among the communities that they serve. It legitimizes peer roles and helps to reduce stigma across the whole system. In New York, the state of New York, strong leadership from the Office of Mental Health helped establish peer certification programs, giving peer workers formal recognition and career pathways. Good leaders support programs and help to shape policy. Effective leaders build support programs that help to shape policy. They advocate for funding, create inclusive hiring practices, and embed peer support into strategic plans. In Philadelphia, leadership within the Department of Behavioral Health integrated peer recovery support into crisis response and housing programs. It influenced citywide behavioral health reform. Effective leaders create space for innovation. They listen to feedback. They pilot new models. They adopt programs based on what works, especially when peer voices are part of the process. If it doesn't work on the street, it doesn't work. In British Columbia, public health leaders partnered with peer-led organizations to co-design overdose prevention sites, resulting in more culturally responsive and effective services. Leadership ensures that peer workers are included and supported and respected. This means fair pay, training, supervision, and the opportunity for advancement. The peer workforce development initiatives in Australia provide structured pathways for peer workers in mental health, backed by national leadership and funding. Perhaps most importantly, positive leadership sustains hope. It creates a culture where recovery is possible and where lived experience is valued and where systems evolve to meet human needs. In Rwanda, leadership in community health programs has embraced peer-led trauma support as part of the national healing efforts, showing that hope can be a public health strategy. Leadership in public health and recovery support isn't just about vision. It's about structure, accountability, and adaptability. Let's explore two foundational practices that help leaders build sustainable peer-informed systems. First, let's talk about policies and procedures. When peer support is integrated into public health systems, it must be backed by clear, consistent, and inclusive guidelines. This means defining roles, responsibilities, and boundaries for peer workers. It means creating protocols for supervision, ethical practice, and crisis response. And it means ensuring that peer support is recognized, not just informally, but formally within the healthcare system, within the community system. Strong policies also protect the integrity of peer support. They prevent tokenism. They ensure fair compensation and promote equality in hiring and in advancement. Leadership must also ensure that policies are co-created with the peer workers themselves. When lived experience informs the rules, the system becomes more responsive, respectful, and effective. Next, let's look at evaluation and adoption. Public health leaders must commit to continuous learning, lifelong learning, not just measuring outcomes, but also listening deeply to what's working and what's not working. This includes using both quantitative and qualitative data, tracking engagement rates, health outcomes, and satisfaction, while also capturing stories, feedback, and lived experiences. Programs should be flexible enough to evolve. If a peer-led initiative isn't reaching a certain population, leaders must ask, why? Why is that? And adapt, change. If a policy is creating barriers, it must be revised. Evaluation isn't just about accountability. It's about growth. And when peer support is part of that process, the system becomes more dynamic, more inclusive, and more helpful, and more hopeful. In short, leadership in public health and recovery support means building systems that are structured enough to be safe and flexible enough to be human. It means honoring lived experience, not just in practice, also in policy. So it builds trust, it builds legitimacy, it drives policy and system change, it fosters innovation and adaptability, it promotes workforce development and equity, it sustains hope and cultural change. It has to be done by establishing clear policies and procedures and evaluating and adapting programs. Lessons learned. From the stories spanning from Kenya to Colombia, and from crisis response teams to prison recovery coaches, what have we learned? Let's break it down into these three key areas that leaders are reshaping how we think and how we lead in public health spaces. First, the public health perspective. What we're seeing is a shift in mindset. Peer support isn't just complementary, it's catalytic. It builds trust where systems have failed. It bridges gaps between the clinical care and the community realities, and it brings cultural humility into spaces that often have been dominated by top-down, expert-driven models. Public health systems are learning that lived experience is not a liability. It's a strategic asset. When peer support is integrated into public health, it improves outcomes, transforms relationships, rebuilds credibility, and makes care more human and compassionate. From the peer support perspective, peer workers are not just service providers, they're system disruptors. They bring authenticity, accountability, and a different kind of data, a lived truth. They challenge assumptions, expose blind spots, and advocate for approaches that center around dignity and choice. Peer support is not about fixing people. No, it's about walking with them. In doing so, peer workers are reshaping the very definition of care from something done to people to something with people. Peers are also modeling recovery, resilience, and leadership, showing that healing is possible and that systems can evolve. Finally, let's talk about hope. Not a feeling. It's not just a feeling. It's a strategy. Hope drives engagement. It reduces stigma. It sustains recovery. And increasingly, we're seeing programs that don't just talk about hope, they measure it. Tools like the Hope Index in Colombia are being used to track emotional recovery and guide funding decisions. Peer-led programs are using hope as a leader indicator of success, because when people believe change is possible, they're more likely to pursue it. Without hope, there is no recovery. Hope is not soft, it's powerful. And when embedded in public health through leadership and peer supports, it becomes a force for transformation. So what have we learned? We've learned that peer support is not a side project. It's a blueprint for the future of public health, one that's relational, resilient, and rooted in hope. Again, without hope, there is no recovery. So now I want to thank you for attending and listening and considering this information. We'll now open the floor.
Awesome. Cynthia, thank you so much. That was incredible. A lot of information, powerful presentation. So we now have time for some questions that the audience has submitted. And please feel free to continue submitting questions while we have a discussion here. So the first one that we received wasn't really a question, it was a statement, but I'm going to form it into a question. It was from Keely. What Keely said was, we need to end overdose death by making naloxone readily available to the community of people who use drugs. Most of the African policies don't allow that. And I guess, so I'm in Canada. My wife and I went to the local Pride event recently, and we walked up to a booth and we received with a very short amount of training, it was free. I've done that in the United States as well. So how can we as leaders provide that accurate information about naloxone, what it is, what it's used for, that it really saves lives, and how do we do that so that worldwide it's easily accessible for people like Peely? Yeah.
Worldwide change starts at the local level. So in your own community, what do they say? All politics are local. In your own community, who are your leaders? Who are your industry leaders? People lose productive staff as a result of overdose, right? Do you know how much it costs to replace an effective staff person? Thousands. So people change often because it's cost effective, or it will change their environment, let's say in their place of business. So my own strategy is to do local, talk to the politicians locally, talk to the industry leaders. It's the industry leaders that push politics, by the way. So what are the industries in your community? Who's making things, building things? Who's helping your city or your town get better or have some role? Get involved in the local politics. Get on a committee. Show them that you're human. When they see that you're human, they'll believe you more. What I did in my community is I got involved with Rotary. It's an international club, right? And who goes to Rotary? People that are leaders, people that do industry. So I didn't really like going to Rotary. It was like, particularly because there weren't that many women and it was intimidating to walk in a room full of men. And they looked at me like, oh, she's strange. Yes, she is. And they said, well, hey, since you're a woman, you can handle the Valentine's program. So the Valentine's program. So find a place, go to a service club that's in your community. Find a place for yourself in that service club. You will be surprised. Give it about, a year. You'll be surprised how people will come to you.
Awesome. Yeah, that's a friend of mine, acquaintance of mine, did exactly that. Started going and giving presentations to Rotary clubs. So this next one's a little bit more in depth. We could probably talk for about 8 hours on this next one, but I'd love your thoughts. Fasua from Nigeria, they said there's a dire need to commence formally a well-structured peer support program in the community where I practice in the southwestern part of my country. How can I practically be best equipped to do this?
Be best equipped to do this?
To start that peer support program.
Well, I think the first thing is to make sure you have your bundle of what is peer support. What is peer recovery support? What does it do? What's the research on it? How is it changing communities and lives? How is it changing environments in schools? How is it changing the criminal justice system in your country? Nigeria, what I know about Nigeria, which is not a huge amount, so I have to say that, is that it is important to hit the politicians in Nigeria, that there's a lot of policy issues. It will help them to understand how peer recovery support will help them run for election, will help them be seen as a leader in their community. Do a recovery support event. So, different months around the world are like pay attention to alcohol use or pay attention to substance use or National Recovery Day, things like that. Do an event. Showcase recovery support. Have literature about it and have people come and talk about it. Have peers talk to peers. I worked with a local radio station and did a peer what's happening with drugs in our community radio show at a mall, and brought in kids and adults and leaders to talk about what is addiction, what is recovery, and how do we get to community recovery. And you get to community recovery by building peer recovery support systems and treatment systems. So doing things that are not usual gets people's attention, because now they're hearing it from the kids. Now they're hearing it from adults in their community. Now they're hearing it from leaders, and it pushes leaders to do something. And that's, you want to sweetly push them to do something. You know, you don't want to like, you don't want to get confrontational. You want to get action oriented.
Awesome. Yes, you know, we talk about, especially somebody, I'm a person in long-term recovery from a substance use disorder, and we talk about recovering out loud. And even if you're not in recovery, you can still recover out loud. You can be that ally, you can be that, and it's really important to discuss that with your community. That's how you start those things.
Right. Who is not in recovery from something? I mean, we all went through COVID worldwide, and I believe we're still in recovery from the outputs of COVID, which created national insecurity, national concern. You know, oh, am I going to survive? What's happening? So I think people can relate to recovery when you talk about recovery in other terms. So if they don't understand substance use, they don't understand mental health, they can understand, oh, how are you feeling about your recovery from the COVID era? You know, open up the conversation that way. And then people are more likely to share because we all felt something in that period of time.
That's right. That's right. So I had a question. You talked quite a bit about youth programs, at least had several slides. And I've gotten this question multiple times about, you know, does this type of information and availability of harm reduction supplies to youth promote the use of drugs? And I'd love to hear your you know, process.
My take on that.
You know, how do you respond to this type of question? Because it's one of those things, especially from parents and other people who don't have experience with substance use disorder. Yeah.
Yeah, I mean, I've heard that for decades. We're teaching kids how to use drugs. Well, let me tell you, nobody's teaching kids how to use drugs except AI, Chat, CPT, you know, friends. Kids can't get away from not knowing about drugs. What's important is that teaching parents how to have the conversation. So when parents say, you know, I know there's a plethora of drugs and alcohol out there, and I love you, I'm concerned for you, I want to make sure that you have the best success in your life, and build that connection. That is what sustains people not using. They did some research on this some years ago. What prevents kids from using? Connection with parents, connection with another adult that they care about, having dinner at the table together, talking about what your day was like. I believe touch, positive touch, is very important. Often as kids get older, parents quit touching their children. They quit hugging them and holding them and connecting with them. So I was a foster child, and one of the things I learned in my last foster home was about touch. And I was a street kid growing up in Los Angeles and was actually gang involved. And I also had some foster parents that were very abusive. And so I had these scars on my back. And when I moved into this home, it was in the summer, it was very hot, and I had on a halter top. And the foster mom comes downstairs and she sees these scars and she doesn't say, oh, how awful, what happened to you? I'm 15 years old. She says, oh, I have these vitamin E capsules that I can open and put on your back, and I believe that those scars will go away over time. So she said, would you like that? And being the smart mouth that I was, I said, yeah, if you have to. And so she would come down every night she was home and I was home and open up these vitamin E capsules and put that vitamin E on my back. I was in that home for 2 years, the longest I'd ever been in one home at one time in my life. And not only did those scars go away, but many of them, most of them, but the scars inside of me went away. Why? Because we know there's magic in positive touch. We know that there's connection. I was just beginning my recovery. That helped to sustain that. That helped to help me feel like a real human. That helped me to feel valued and wanted and cared for. That's what kids need. That's what changes people's lives. It's not always about a fancy program. Sometimes it's about fancy care. And that's what peer recovery support specialists do, is fancy care.
That's right. That's right. I think we have time for at least one more. And this one, I'm going to kind of jump a little bit, but so there was a question about pregnant people and withdrawal at the time of pregnancy. And I kind of want to link that to integrating care models, which you spoke of quite a bit. And I've heard so many stories, and not just anecdotally, in research as well, that there seems to be a lapse of training or recognition in emergency rooms, emergency departments, primary care physicians about substance use disorder, about recovery, and especially about peer supports. What can we do as leaders to really inform that? Because to integrate recovery and peer support into the healthcare model, not just worldwide.
Right. So integration is there. Companies are seeing this, emergency rooms are seeing this as healthcare costs go up. And so they're looking for ways to reduce the cost of healthcare. Introducing peer recovery support services in emergency rooms on floors, particularly where people have had substance use related medical issues. It's important to have those conversations with administrators because they may not recognize the change. Ask them for a 6-month pilot or a 1-year pilot. Let's try this. And if it doesn't work, okay. I will also say that treatment centers need to be bringing PAs, physician assistants, into their services. So you can, in some countries, they can bill, for physicals, medication support, giving, particularly for pregnant and parenting women, giving them regular checkups, giving them other supports. So I think that oftentimes you're the person who's going to have to introduce it, and you're going to have to introduce the research, as I said, about the other issue of peer recovery support, and look for money. So in your community, again, how are the hospitals funded? Are they funded through the government? Because if they are funded through a government, then you know that you've got to go upstream through that government process to get funding for, let's say, a pilot, funding to try it. People often don't know what they don't know until they do it. And so that's part of what we do, is help support the idea of doing it. So I just want to support you. Do it. Know it's going to take time. It's not going to be an overnight success. And don't give up. It took us 16 years to get parity in the United States. I fought all 16 of those years to get parity, and we got it. So
Thank you. All right. Awesome. Again, thank you, Cynthia, for helping us continue this series with your in-depth experience in leadership and public health. And thank you to all of you for being here. As we've heard today, recovery is not one size fits all. It is shaped by personal experience, by culture, by access, and by community support. As we continue this journey together, we invite you to reflect on how you work and honor and uplift those affected by substance use disorder. So for everybody, you'll receive a follow-up email shortly with the webinar recording, slides, and additional resources. Please also take a moment to complete the short feedback survey. We love your thoughts, and it helps us going forward. We'll see you again in 2 weeks on International Recovery Day, September 30th, at the same time, 9 o'clock Eastern time, as we end this series with elevating leadership, a strength-based, heart-centered approach to leading. Until then, thank you again and take care.
Bye. Thank you.
Thank you.